Okay. Well, thank you everybody for being here this morning. Um, Before we kind of jump into things, I wanted to say there's a lot of information in the training that I'm hoping to get through. So I'm going to ask that discussion, questions be saved till the end. I've been rehearsing and I think I can end this around 70, 75 minutes and so then have, a little bit of time for that discussion afterwards. If it's easier for just to write questions into the chat, you can send them there. But I'm just letting you know I will be ignoring those until the end of the presentation, and then we'll get back to those. Any questions before we get started? Fabulous. Okay, let's pull up my right screen. Can everybody see this okay? Fabulous. So as I mentioned, yeah, thank you so much for coming today. Um, I wanted to share a little bit about myself as we get started and what has kind of drawn me to this type of work. So my name's Amanda Kieser. I'm a therapist here at Self Space. I've been working within mental health since 2013, but was able to graduate and get my license in counseling in 2020. During my final year of grad school, we needed to complete an internship, and I was able to get connected to a residential facility treating people struggling with eating disorders. And this is really where I started to not only get exposed to different types of thinking around weight, but started to also learn about things such as health at every size, weight bias, which we're going over today, and fat liberation ideas and that community. I started to get really passionate about all of those things, not only as a provider, helping the clients I was working with at the facility, but also for myself. I'm a person who's lived in a larger body my entire life, and some of these things were really helpful to validate my experience in. And I also started to notice how much we don't talk about these types of things. So much so that I ended up writing my grad school thesis about weight bias and why it should be taught as a form of discrimination in counseling programs. So really, this is like the evolution, it feels like, of my original thesis, hopefully with some more updated kind of information, which I just find really exciting to be able to keep doing this type of work. So listed here are the goals of today's training. The first one is to explore some of these beliefs or biases that either society, culture, or we may have, not only towards higher weight, but especially fat people. And in that, there's oftentimes a lot of what I would consider myths or some outdated kind of thinking or misunderstanding of concepts related to fatness. So we're going to be debunking a few of those common myths. We also hope to raise awareness on how harm towards fat people happens and how we as healthcare providers can potentially prevent it. And then lastly, very so lightly, we're going to touch on the pervasiveness of eating disorders and how we can keep an ear out for possible eating disorder behaviors and actions happening with our clients. So you might have noticed so far that I'm using the words fat, fatness, higher weight, larger body. I wanted to say that this is intentional. These are not bad words. These are purely descriptors of body size that we see not only across, America, but across all of human diversity around the globe. And that this is what the words I want to be using today. Unfortunately, words like obese, obesity, even overweight tend to be outdated and are seen as slurs, especially in fat liberation places, because they're steeped in stigma. Those terms have often been used to medicalize fat people, which also further dehumanizes fat people. So I'm going to ask that we do not use those terms, especially during discussion and question time. Unfortunately, when doing the research around weight stigma and weight bias, the research is steeped in these outdated slurs and terms. So there will be quotes that I have to directly, put on the page here, but I will do my best when speaking out loud to not use those terms and instead use words fat, fatness, higher weight. And this is my first big request to all of you. As we know, bias training can stir up a lot of different feelings. Sometimes that's uncomfortability, sometimes that is guilt or shame, embarrassment. And I just want to say that that's normal. Um, I hope that some of you have gone through bias training already in your career. And just know that that is often the process of bias training. That doesn't mean, though, that we can't do things to maybe better take care of ourselves today, not only during the presentation, but especially following today's presentation. So if we need to turn our camera off, step away, I think all of those things are really reasonable. I also wanted to say that I will be mentioning some resources at the end of today that are hopefully some places to go for not only further education, but maybe getting like some consultation or ongoing support. Um, and please, if this feels like something you want to talk more about, do so. Again, I think that's going to be a theme today, is that this is often not talked about. So if you're feeling yourself having a lot of reactions or feelings, that is normal, that is okay. And I hope we can find a source for you to get some support. All right, well, my first thing to explore, just individually, privately to yourself, are asking, what are the myths you have heard about weight? These can be things that you don't believe yourself, but have instead interacted with or observed in culture, in social media, in Hollywood portrayals. What are the beliefs or ideas that you have heard or have held, perhaps at some point, about higher weight and fat people? Please go ahead and take a moment to privately do so. I'm not going to ask anybody to share these, but I'll give everybody time to do so. I hope that was enough time to start letting this percolate and what kind of ideas come up. Like I said, I'm not going to ask anybody to share these, and this is for two large reasons. The first being that I think we would be here all day if we tried to go through every single myth that everybody has heard of around higher weight and fat people. Especially once you get into it, there's a lot of ideas that start coming up. But secondly, my real big hope for today is to minimize harm when possible. As we know, some of these ideas are really hard to not only interact with, but just to even overhear at times. So we won't be sharing them today, but I would be curious on a personal level if there's any myths that we did not go over today that maybe you would want to talk about more. And again, I'll share some spaces where that can maybe happen. So let's first define what these things mean. So weight bias is made up of negative weight-related attitudes, beliefs, assumptions, and judgments towards individuals who are fat or in larger bodies. So it's not, just behaviors, right? It's all these different levels of weight-related kind of thinking. There is a growing field of research called fat studies. And fat studies actually defines weight bias as a system of oppression that intersects with biases based on other areas of difference: gender, race, age, and so on. I tend to agree and believe this definition that weight bias is a form of oppression. And I do so because I can also recognize at times the other systems of power that not only uphold weight bias, but really perpetuate it. Some of these systems of power are not only white supremacy, racism, sexism, but also capitalism and anti-Blackness. There's a lot of intersections when you start looking at all of those different systems of power, and somehow it all winds up related to weight. Similar to these other isms, racism, sexism, weight bias can be both implicit and explicit. An implicit bias, meaning something that is unconscious. I, as an individual, don't have awareness that the belief I have perhaps is biased or skewed in some way. All the way up through an explicit bias, meaning I do have awareness of it. I am conscious that I hold this certain belief towards this group. Um, so when we are looking at these things, right, it can be really then just really tricky to actually start unlearning or deconstructing some of these ideas, especially if we don't have a ton of awareness around them. So I just wanted to say that as well, that without awareness, it's really hard to like make changes to our own thinking and then of course our own behaviors. So let's jump into our myths. The first place we're going to start, you'll notice that this is a 2-page myth here. But first, let's just question, weight bias isn't that bad. You might have thought that um, even since I've been talking so far. Um, so why is it that maybe I have this point of view? As this quote from 2017 says, after gender, age, and race discrimination, weight discrimination is the most common form of discrimination in adults. I gotta say, every time I read that, I think I am shocked that it's the 4th most common form. And yet again, we just rarely have this type of discriminatory conversation related to weight. When in the research, I was able to find an older article from 2010, but that article stated that weight-based discrimination had increased 66% from 1995. So within 15 years, we saw a 66% raise. And unfortunately, I think this second article backs up that this has not really changed or gone away. We're not seeing a decrease in discrimination based around weight. So where does discrimination and how does discrimination show up when in regards to weight? What we first see is really in the employment sector. People who are fat are hired less, promoted less, and paid less. Um, Obviously, right, on every level of employment, fat people are on trend to be less hired, less paid. We also see this, though, in reproductive medicine, home ownership, health and life insurance, adoption, and of course, the fashion industry. That people are excluded often from these areas, or it's very barriered to get into, say, home ownership or life insurance. Um, and, you know, I hope we're starting to see that there's not almost not an area of life that can be impacted by this. We also know that it's not just a fat person's individual experience, but also our community and our public spaces. Public spaces are often not made to be inclusive, whether that be by only having small chairs or chairs with arms that are not movable, small paths and walkways that one has to navigate through to get to a certain area in a space, lack of sizes in medical equipment, such as not having gowns or health cuffs to do, screenings, but also lack of sizes in clothing stores. Very common experience for fat people is to walk into a store and not find any clothing that would fit them. So again, right, it's in multiple areas, almost all areas of life where this exclusion and discrimination is happening. Based on our definition of weight bias, though, we also know that weight bias can carry attitudes. Discrimination is what we maybe look at in the behavior section, but what are these attitudes maybe lead to? Weight bias attitudes can often include a thin preference. This came up a lot when I was doing research around medical students and their opinion about who they would prefer to work with as a patient. And many medical students voiced rather wanting to work with thin people over fat people. So already going into, a work setting or a career setting with an idea of, I would much rather work with this group over this group. We also see a lot of labeling of fat people with weight biased attitudes. I'm sure we've heard these things before, right? Fat people are lazy or they're disgusting, they're careless, they're undisciplined, they have a lack of willpower, and so on. Very, very much tied to the stereotypes, I think, associated with fatness. We often then also see this labeling as fat people as ill or diseased in some way, that they're inherently unhealthy or sick simply by being fat. We also see that people expect a poor performance from fat people, which I guess, in my mind, I can easily see that jump if I'm already labeling the fat person as careless or undisciplined. It feels like an easy leap to say that I would also expect a poor performance from them. But lastly, also the allowance of making inappropriate comments. This is a common experience that people have where people feel justified or allowed to comment not only on their body and what it appears to be, but also their engagement with food or their engagement with exercise. Things that normally you would not say to other people. But there's this feeling of, I'm allowed to do this because maybe you feel like you're coming from a place of concern or care, but still it leads to um, just making inappropriate comments to somebody unsolicitedly. So I'm going to show a pretty large quote at first that I think really encapsulates how these types of attitudes can then progress, right? We know we have discrimination happening, and then these attitudes also maybe driving some of those things. But what are the other repercussions we see? A big one is stigma around fatness. So much so that this becomes a public health concern. I'm sure many of us have heard fatness at some point in our lives referred to as obesity epidemic, meaning it's taken a level of public health crisis that needs to be intervened with. And a lot of this, in my opinion, has been driven by weight bias thinking. And an outcome of that is what this quote states. Some public health strategies openly embrace stigmatization of fat people based on the assumption that shame will motivate them to change and achieve weight loss. So there's this open shaming that was believed to really curb people's behaviors, and that if you feel excluded, if you feel bad about yourself enough, that will drive you to be different. I'm sure as many of the mental health providers in the room right now can guess, shame is an awful motivator. And actually, what we see, as the quote continues to say, most studies show that these strategies result in the opposite effect and lead to exercise avoidance, consumption of unhealthy diets, and increased sedentary behaviors, which long term may lead to poor metabolic health, increased weight gain, and just an overall reduced quality of life. So, using shame as a motivator tends to backfire and actually results in a lot of the things that supposedly we are concerned and don't want fat people to engage in. And I get it why shame was not going to result in these things. And again, we can understand that if you believed all these things about fat people, making them feel bad, right, would change their behavior. Unfortunately, we see this in real life happening to this day. What this also tends to lead to, though, is healthcare avoidance. Unfortunately, healthcare are some of the most frequent places that clients are maybe feeling this shame or hearing these types of thinking and beliefs. So it makes sense to me that if every time I go to my therapist or my healthcare providers and I get shamed, I'm going to stop going. It does not feel good. We also then, of course, see increased fat phobia or anti-fatness and the further dehumanization of fat people, right? We can't even treat fat people in this clinic because we don't have the materials or the equipment. So you're not wanted, you're excluded, you're othered in that process. And lastly, diet culture is a huge consequence of this open stigmatization, open shaming. Diet culture is defined as a system of beliefs that values thinness. It equates thinness to moral virtue and promotes weight loss as a way to attain increased status or power. So this general push or pressure that thin is the only acceptable way to be, and by being thin, we'll treat you better. You'll have more power. You'll have more status. Obviously, those things are very connected. Publicly shaming or openly shaming people, and why the pressure to be thin feels so intense, feels so high. So knowing this, more research has then been done to explore, okay, well, what are just the impacts of weight bias and weight stigma? What we find is that weight stigma, rather than fatness, may be particularly harmful to somebody's mental health. This can show up as internalized shame, guilt, anti-fatness type thinking. We also see that weight stigma increases the risk of a high allostatic load. A high allostatic load being referred to as the wear and tear stress that all humans have throughout their lifetime. Unfortunately, when chronic stress around a similar idea over and over again happens, this can lead to really bad dysregulation. which makes sense, then leads to psychiatric and or substance use disorders, and even suicidality. These things are really intense when they're internalized, and unfortunately, that can result in people wanting to take their own lives. Suffice it to say, I do believe weight bias is that bad. All right, our next myth: weight is completely in your control. I'm 33, and this is something I've heard my entire life. And what I often refer to this type of thinking with my clients as is some equationing happening. And that equation often sounds like eating less plus moving more equals thinness. And this is inherently not true. Americans don't have as much control over their weight as they'd like to think. Research suggests that our bodies are much more a product of our genes and our environment than of our willpower. Um, as we know, our genes and our environment, nature versus nurture debate, still here, um, tends to have a much higher impact on somebody's overall body physiological responses, and how weight is held or distributed across somebody's body. And most studies rarely take into consideration genetic components or environment components. So these have much more of an impact. And a way we see that is because major reductions in weight tend to be temporary when somebody is intentionally trying to lose weight. Most studies show that 1/3 to 2/3 of dieters regain more weight than they ever lost on their diets, which, as we can imagine, is really demoralizing and defeating to somebody who's wanting to pursue this. And again, we don't talk about it unless we're talking about it to normalize weight bias thinking. For example, if you were around in the 90s and the early aughts, you've likely heard the term yo-yo dieting. Yo-yo dieting was meant to encapsulate and describe the pattern of somebody starting a diet, losing X amount of weight, not being able to maintain the diet, whether due to life stress or circumstances changes or the unsustainability of said diet, followed by weight gain, likely more than they had lost. And that is so common that we termed this phrase yo-yo dieting. And the thought process wasn't, maybe this whole pattern is ineffective. But the conclusion, especially back then, was, well, it was that diet that didn't work. So I will try a different diet or a different exercise routine, and then I'll see the results I want. So we only talk about it to normalize that the pursuit of thinness is still wanted and still something you should be doing. But these are kind of the rocky roads you'll have to go. We no longer call it yo-yo dieting. We now refer to this as weight cycling, the repeated pattern of weight loss and weight regain. And unfortunately, weight cycling has some pretty impactful consequences. Weight cycling is associated with numerous adverse health outcomes, including increased mortality. So weight cycling alone can unfortunately decrease the longevity of somebody's life. Other impacts can include cardiovascular risks, vascular injury, and building insulin resistance in somebody's body. Whereas long-term impacts can look like increased risks of developing an eating disorder, type 2 diabetes, hypertension, cancer, and bone fractures. So what we're seeing is that weight cycling alone, this pattern of weight loss and weight regain, is actually really damaging. to our bodies and to our systems. Um, and so weight is not completely in our control. And often when we try to intentionally manipulate or change our weight, um, instead we just go through this pattern of weight cycling. All right, our next myth, being fat makes you unhealthy. Again, this is some equationing. This equation sounds a little different though. It sounds very simple. Fat equals unhealth. And I gotta say that this is often a pretty large sticking point, especially with the clients I work with around body image and their relationship with their body. And I think this is because this has been an inherent and unchecked truth for a very long time. But how did we get here? How did we even get to this association? There is this historical belief that fatness is not only a problem, but that you are now inherently unhealthy simply by being fat. And one of the reasons I believe this gets perpetuated is that there's myths within myths here. Our first one we're looking at is using a BMI measurement as an indicator of health. A little history about the BMI, or body mass index, which is a ratio taking a person's height and their weight, comparing those together and producing a number. The BMI was created in 1832, so quite a while ago, by a Belgian mathematician, not somebody trained in medicine, not somebody working within healthcare, but a mathematician. And he was exploring, trying to find the ratio that determines the ideal man. And so the population he was observing and getting these numbers from were white cisgendered men. So that means if you are not a white cisgender man, the BMI is inherently skewed from the beginning towards you. And as I said, it was not meant, it was not created as a health indicator. Yet over time, it has been, co-opted a bit here to be used as a health indicator. So research has looked at, well, how consistent, how reliable is this indicator? And the studies say that except at statistical extremes, BMI only weakly predicts longevity, only weakly predicts how long we can expect somebody to live. And that's still only at statistical extremes, meaning the very far sides of the bell curve, still only weakly predicts. Most studies find that people who are fat live at least as long as thin people, and often longer. When I was doing my thesis, this, kind of surprise findings that was coming up in a lot of the research, it was often referred to as obesity paradoxes. We don't know why that's happening. It doesn't fit our paradigm of what we would expect, so it must be a paradox. So we're really, right? Like, I think that just highlights how steeped in this idea is. I don't think it's a paradox. I think we're finding that BMI is not a good measurement of somebody's health. So, okay, the BMI is not great. What else perpetuates this idea? We know that fatness is associated with an increased risk for diseases, but causation is far less established. Studies rarely acknowledge factors like fitness, activity, nutrient intake, history of weight cycling, or socioeconomic status when considering the connections between weight and disease. It is likely that these other factors increase disease risk at the same time they increase the risk of weight gain. So this quote, I think, is perfect. It just highlights, right? We rarely take into consideration all these other sectors of somebody's life. And it's far more likely that fatness is a side effect or impact, a response to these other things versus the cause of a disease. Um, so I don't think we have a lot of proof here or evidence to me that fat inherently makes somebody unhealthy. Okay, our next one here, another big myth to try to debunk and look at. I wanted to say again, my intention here is not to offend or judge or shame any of us here in this training. And what we do know, especially about the healthcare profession, is historically, um, healthcare has been a place of harm for many different groups. So my intention at looking at this myth specifically is to raise our awareness of how that happens when connected to weight. So it is pretty obvious that our medical system and medical schooling is often based on weight biased research. That is the most prolific amount of research that we have right now. So most of our medical students and personnel are being trained from that biased research. If this is how we're training medical providers, not only are they set up to have a further bias, but they are also likely untrained in how to provide weight neutral care. So when we know that all people carry biases, we can, try to accept that, try to work on this is a bias this person may carry. But medical provider bias against fat people often results in the assumption that those in fat bodies have less interest in their health, which then can lead to medical providers spending less time with fat patients in appointments, increased impatience towards fat patients, a decreased willingness to work with fat patients, more of that thin preference that I described earlier, increased frustration towards patients when they're not losing weight, especially if that's what's been prescribed or recommended to them, keeping inadequate medical equipment for all body sizes, again, kind of tied to that open shaming. We think that shaming is going to motivate you to change. So I won't keep in stock the things that would make you more comfortable because shame doesn't really want that person to be comfortable. But lastly, this lack of education for caring for not only fat bodies, but people of all sizes. What that can look like is things like how to draw blood, from a fat person, how to best position a body for scanning or imaging, how to do physical examinations where you have to, actually physically touch somebody and feel through muscle or what we're looking for. Um, just really a large disservice, right? I feel that we're providing to our medical professionals. So when we have, clients and people who are being shamed and perhaps even neglected by healthcare providers, as we said earlier, this can lead to healthcare avoidance. Avoidance of healthcare is often contributed to past advice around intentional weight loss that is perceived as unhelpful to the person, or it's unsolicited. When I say it's perceived as unhelpful, what I mean by this is fat people often experiencing being diagnosed as fat, aka any health concern that I have as a fat individual is related only solely to my weight, oftentimes without any further testing or examination. and that this encouragement of weight loss by any means necessary, it feels like at times, can sound like healthcare providers recommending calorie restriction, calorie counting, intense engagement with exercise, which, spoilers ahead, these are types of eating disorder behaviors, but also medications. Um, Unless you've been living under a rock this past year, you have likely heard of Ozempic or Wegovy or any of these new weight loss medications. But even so, we've had various surgeries for many years now to treat fatness, right? To get rid of fatness. So almost on any level of intervention, we have something um, that healthcare providers have suggested to people. And so the consequence of weight-focused care, weight-biased care, leads to food and body preoccupation in our clients, weight cycling, distraction from other personal health goals, a reduced self-esteem, eating disorders, weight stigma, and weight discrimination. So again, this is kind of just like a bad cycle that weight-biased care leads to not only all those things, but to further stigma and further discrimination. And the ways in which weight discrimination and weight stigma often appears, especially in healthcare settings, are things such as being denied surgeries or certain procedures until you've hit a certain weight or X amount of weight has been lost. Also, insurance denials. So we'll see insurance companies interact with this as well. I had some firsthand experience when I was working at the residential facility where I would have to often call insurance companies to continue somebody's treatment. And when I had clients who lived in larger bodies, it was really not uncommon that, especially if they were engaging in restrictive behaviors and had an anorexia or atypical anorexia diagnosis, insurance companies would cut them off based on their weight. They would look at a person's weight and say, they can't possibly have anorexia. They're too fat to have anorexia. They don't need treatment anymore. So in real time, I got a glimpse into how this weight discrimination really shows up, even when people are actively needing care, even when their providers are saying they actively need. So I think this myth is, not against doctors per se. It's really alluding to how we have done a disservice for many of our providers, but also the power differential that is, true for a patient-provider relationship. And so many fat people have voiced this feeling of, I can't push back. I can't ask questions. I can't ask, what would you recommend to a thin person? Because that feeling of this is the expert in the room and they must know what they're talking about, even if it feels incorrect to me. Okay, this is our last myth for today. The idea that eating disorders have a certain look to them. What I mean by this is what is the visual image that comes to mind to the general population when we talk about somebody who is struggling with an eating disorder. So what do we know to be true about eating disorders is that there are serious psychiatric disorders that occur across the body weight and size spectrum. And yet, the ED look is often only associated with thin or small people. This ED look I'm describing often includes characteristics such as somebody being frail, gaunt, perhaps emaciated is the term coming to mind. They appear, fragile. And that is, not only the idea that so many people have like associated, but the idea that gets perpetuated, especially in media. When we're talking about eating disorders, this is the look that somebody has. And in my
We
experience,
probably need to go soon.
no problem. um, the the media perpetuates this kind of idea as well. But in my experience, most eating disorders don't include visible physical changes. You might have some, but the ED look that I just described is much more common in a very severe, very specific eating disorder presentation. So what we also have here is another myth within a myth that fat people can't have an eating disorder. Women with lower body weights are much more likely to be diagnosed with an eating disorder, whereas women who are fat are approximately 85% less likely to receive treatment. 85%, so that's almost all of this group. And that's, of course, really, really scary when we actually think about that. And this myth that fat people can't have an eating disorder, I believe, again, stems from because thinness is the value here, right? We want people to be thin no matter what, lose weight at any cost, even if that means you're actually engaging in an eating disorder. As I said, fat people are often prescribed or suggested to engage in behaviors that are eating disorder behaviors. And when we look at the percentages, anorexia affects up to 3% of young women and has the highest mortality rate of any psychiatric disorder, with approximately 5% of patients dying within 4 years. Death complications following eating disorder diagnoses often are due to issues with diabetes, pneumonia, but again, also suicide. Highest mortality rate because, again, I think it's easy for my brain to make that connection that there's this open shaming, open stigmatizing that can lead to a lot of self-rejection and yeah, having thoughts of suicidality increase around. So as I said, that's our last myth for today. But I wanted to highlight, go over some possible eating disorder behaviors because again, I think not only do we have maybe an association with an ED look, but we have an idea in our mind of what eating disorders often involve in some way. So there are 3 large categories of eating disorder behaviors that we're going to look at. The first, and most likely most well known, are restricting behaviors, which is the intentional restricting of food and fluids. But this can also sound like cutting out whole food groups, such as I am not eating sugar, I am not eating carbs, right? Just kind of this blanket exclusion of an entire food group. There's also a lot of evidence pointing to the development of a newer type of eating disorder that is referred to as orthorexia, where a person is only allowing themselves to eat foods that are clean or good foods. And this can result in malnutrition due to not having easy access to clean or good foods everywhere a person might go, or not being able to really sustain that type of diet. The second category of behaviors we're looking at are purging behaviors. Again, I think a more common or well-known type of eating disorder is bulimia, where somebody is purging through self-induced vomiting. But purging, by definition, is the intentional offsetting of what somebody has ingested. So the offsetting of food or calories that somebody has taken in. So purging can also look like excessive exercising, or laxative, diuretic, or insulin misuse. These last three, the laxatives, diuretics, and insulin, are often a way that a person can manipulate their GI system, so that food passes quicker than your natural body process would take. The idea here, I think, is that by passing food quicker, you're not actually allowing your body to break down and store or use the nutrients from food. Lastly, we have binging behaviors. Um, Binging is defined as eating a larger amount of food than others would typically eat in the same time frame. You'll notice that that's pretty subjective as a definition, but that is because every person needs different amounts of food, day by day, sometimes hour by hour. So the idea here, right, is that it has to be a larger amount of food than what another person would likely eat in that same time frame. The other facets of binging, though, have to also involve that a person really struggles to stop this behavior once it has started, and that the end result is in physical and emotional discomfort. So that feeling of fullness that's like extreme and unpleasant, and the emotional pain, perhaps of embarrassment or shame or guilt, loneliness. Um, so these are all possible eating disorder behaviors. Um, and in my experience, it's much more common for people to interact with kind of a mix, a blend of these things, versus sticking to just solely one category, which then makes it harder, right, to really pay attention and really pinpoint what's happening. So, what can we do as healthcare professionals now, knowing this information and maybe having some changed awareness around it? The first thing we can do is not make assumptions. Assumptions such as weight is the problem, or that a fat person is seeking weight loss, that a fat person has issue with their weight. Making these types of assumptions often can be invalidating, right, to our clients. We can also acknowledge that anti-fatness and diet culture exists, that weight bias exists. Um, this can be extremely validating for clients to hear, especially from healthcare professionals. Um, it not only can normalize and show some understanding of their lived experience, but it also might clue them in that we have done some work here. We've done some educational training for ourselves to see how this actually plays out in the real world. We can practice weight neutral care. So again, not defining weight as the problem, but instead going through testing and investigation, screening, to gather the whole picture, all the information that we possibly can, versus only looking at somebody's weight. We can keep an ear out for signs of disordered eating or an eating disorder. Um, I know that those eating disorder behaviors that I covered are kind of, the surface level of this. But I also wanted to validate that disordered eating, especially in American culture right now, is fairly normalized. Whether that be by, as I said, eating clean or cutting out whole food groups, intermittent fasting. These are all ways that we can start forming some disordered eating, and yet it's very common for most people to have engaged with some of this at some point. So we can also engage in harm reduction practices when possible. Um, this can look like having different size instrument, clothing, furnitures for all bodies, for any person who comes to your space. Um, Clothing, in a medical office might mean having gowns run from sizes extra small through a 4X or a 5X. Making sure that your furniture has a high weight capacity. What's recommended is usually at least 500 pounds for weight capacity for your furniture. And then also having, different types of furniture. So you can have chairs with arms, but also maybe having a couch or a love seat or chairs without arms. I found this one using scales that are digital can be a harm reduction practice. I think the comparison here is to the scales that are manual, which I saw a lot when I was younger. Luckily, I haven't interacted with these in a while, but it's those scales that had those two metal bars that you had to like move that little brick along to find somebody's weight. Those are inherently slow to get somebody's weight, pretty clunky, pretty out in the open, whereas digital scales, are quicker, can easily be, the screen can easily be hidden so that a person, doesn't maybe see their weight if they don't want to know their weight. So using these kind of updated forms of technology can be a harm reduction practice. We can also practice consent when discussing body and weight. Fat people are often not given the choice not to talk about their weight or how they feel about their body. So if you have a person who is voicing or saying, some things that make you curious about their relationship with weight and body, I would really recommend asking, I hear you saying these things. Is this something you want to talk about? The risk, of course, is that they might say no. And I think that is much more empowering. Not only are you saying, I will respect your choices and your autonomy, but we're also planting some seeds that this is something I would be open to talking about when you're ready, if you are ready. And of course, we can continue to seek out further education and challenging or unlearning our own biases that we might carry. So here are some of those resources I was mentioning earlier, not only for some like continuing education, but hopefully some places where you can get some support. The first three here are some books I would highly recommend. Health at Every Size by Dr. Lindo Bacon is one place that really goes into the ideas of health at every size as a concept, and why not only is that likely more effective for our healthcare, but that it is much more compassionate as well. Second, The Belly of the Beast, The Politics of Anti-Fatness as Anti-Blackness by Deshaun Harrison. If you're looking for some historical context, especially through the lens of anti-Blackness, which so much of our anti-fatness is actually related to, this would be an excellent source to turn to. And then What's Eating Us? Women, Food, and the Epidemic of Body Anxiety by Cole Kasdan. is a really wonderful book. I do have a bit of a content warning. Cole Kasdan struggled with an eating disorder herself. So this book is part her discussing her experience with an eating disorder, but then also going and researching what we know about weight, what we know about eating disorders. And there's a lot of interviews that she does with experts in this. If podcasts are more your speed, highly recommend the Maintenance Phase, which is with Aubrey Gordon and Michael Hobbs. The tagline for their podcast is, "It debunks junk science behind health fads, wellness scams, and nutritional advice." Or the Everybody podcast with Kristen Erickson. Their tagline is, "Countering myths about food, bodies, and dieting." So likely these two podcasts would, be going over some similar ideas you've heard here today. If you are a physician and wanting a more tailored approach, there is a training currently on PESI by Dr. Lisa Erlanger titled "Untangling Weight and Health: A Physician's Perspective." That could be really beneficial. But we also have Dr. Lily Stokely at One Connection Healthcare, which has an office in the Ballard neighborhood here in Seattle. She offers provider-to-provider consultation on HAES and weight inclusivity. But lastly, myself. I would love to be of support, be a place of continued conversation around these ideas that we covered today. So my email address is on the screen there. I would love to connect further with you if you would like to do so. And emailing me is typically the best way to coordinate that. So thank you. That is the bulk of our training today. I'm glad we have some time left over. But really just a massive thank you for everybody. I feel really grateful that these types of trainings can even happen and that so many people have signed up for it. I hope you can feel some pride and accomplishment that you are taking a really big step in reducing harm for your clients and for any person that comes through your door. So I'll go ahead and stop sharing. I have some things to hear in the chat that I would love to be able to go through. But also, like I said, if people have questions or things like that, I want to open that up. So it looks like a lot of the messages in the chats were some messages to me. So I'll open it up to the crowd here. Is there anything, questions, points that maybe need some clarity around? Or any reactions, those are welcome too.
Yeah, I would first want to just say thank you so much for this session. This was so meaningful. And the question that I have is related to, how we can be most helpful to our clients who are living in larger bodies, who are fat, and who have been really impacted by sort of the internalized stigma, who really have like closely held goals to lose weight, who are looking at these options from their doctors, like take Ozempic, and then we're over here trying to offer, radical self-love and radical acceptance and health at every size, and it might sound like a harder sell in some ways. And of course, like motivational interviewing, always helpful with situations like this. But more specifically, do you have any, I don't know, thoughts on like language to use, ways to open that conversation, how to be most helpful when, the client is just living with a lot of that internalized stigma and is very motivated toward thinness? Yeah, thanks.
Yeah, great question. This is hard. It's definitely a hard position to be in, especially if you're, like myself, who is a fat liberation, anti-weight bias type provider. So I think one thing we could try to explore, perhaps if a client is open to that and is willing to have that type of conversation, is, tell me about what your hopes are here. What's motivating you to pursue these things? In line with that motivational interviewing, like what specifically is here for you? And then sometimes I like to ask a question of, what would it be like if these things weren't happening? Or, what would it be like to not feel pressure to lose weight? Um, and oftentimes clients, report having like relief, or that feels nice. That would feel like really peaceful. And so then using that maybe as like some wiggle room of what makes it hard to let go of this desire to lose weight. Reality is losing weight for many fat people would inherently make their lives a bit easier because our world is built up in an exclusive way, right? It would be easier for me to fly a plane if I was smaller. It'd be easier for me to attend a concert if I was smaller. And that intentional weight loss pursuit often brings so much shame, so much guilt, so much disappointment, kind of highlighting for a client, maybe it doesn't have to be that way, and validate the reality of how hard it is while also maybe exploring what they want personally. That kind of answers the question there. Yes, Tychell.
Thank you. I thank you again for this as well. Echoing that same thing. It's interesting because I think the first time I thought about not losing weight in this context was my I would think I was probably in my 20s, and my best friend said to me, "What if you never lose?" And honestly, I thought it was like the rudest thing she could ever have said to me. Like I thought because I had never pictured myself as a fat adult.
Yeah.
But she said to me, "What if you never lose weight?" And I was devastated. But what it helped me realize was like, I need to live my life now instead of in the hopes that I would always be trying to lose weight. And it really shifted for me. And not that I would say you should say that to a client in that way, but by asking those questions, because I had never considered that I wouldn't lose weight. Like my entire life thought process was that I was going to. And that's what, so in my brain, I couldn't even see myself as a fat adult, like just never. So just that concept helped me. Like I started to dress better because it was like, well, why am I waiting? We all have that Pinterest board of clothes. Well, back when Pinterest was the thing, of clothing that we were going to wear if we were thin or if we lost this weight. So just that concept. The other thing so that was the comment that I was thinking about, sort of comment question, just thinking about um, fat liberation and understanding how this plays into one, race, and also capitalism, as you talked about early in the beginning, but really also thinking about how fat liberation is different from, and body neutrality are different from body positivity and like this. So I'm just like pondering what that looks like, because when we think about things like job prospects and more things, when we're talking about what you look like and how much you look, how much somebody finds you attractive, but more how it has disparities on larger parts of life, like income and there's part health, but also understanding this. I don't even know if there's a question in there. I was just thinking if maybe you could talk just a little bit more about fat liberation and understanding from the specifics of like body neutrality.
Yeah. Yeah, excellent question. And thank you so much for, yeah, sharing your personal experience there. To me, the biggest difference between like a body positive movement versus like fat liberation um, are the inherent goals of the systems of power kind of at play. Um, right? Body positivity rarely acknowledges like the oppression that I was just talking about today in the discrimination and the stigmatization that happens. Body positivity is much more of an individual. I want to feel positive about my body, which is great. Love that as a goal. And in my experience, especially doing this work, body positivity is really hard for many people to actually get to, just because there is stigmatizing, there is discrimination. So fat liberation instead says you don't maybe have to change your individual perspective on your body. That's not what's needed. What's needed is a dismantling of this system of power and acceptance that fat people have always existed. They will continue to exist. And let's not treat people differently purely based on their size. Great question. Yes, Natalie.
Thank you, Amanda, for this. It's been really wonderful. I was thinking a little bit about how I, in my practice, have been really, I think I was naive about it, and I've been dismayed to find how often in kind of Hazel-aligned work, I find myself at odds with people's other healthcare providers. And sometimes that means a direct conversation with that healthcare provider, which is its own can of worms. And I think more often in my experience, it means kind of speaking through the client, or engaging with the cognitive dissonance of having two different healthcare providers saying very different things, and also like being a therapist and not having medical training, not pretending to have medical training, but that being easier to dismiss than say a doctor. And so I was wondering if you have any sort of like rule of thumb scripts that you use. I find the phrasing really hard, for adding that like little bit of doubt or the possibility of a different perspective without completely alienating someone who is fairly aligned with arguably like a fat phobic doctor, for example.
Yeah, excellent question. That is, I mean, you never want to like villainize other providers, right? And also, I guess for me, what comes up there too is we know healthcare avoidance is like a large consequence of these things. And so if people are connected to healthcare, I don't want to like further cause that avoidance. So one thing with clients, I might talk about is, how did that make you feel? What was that like for you hearing all of these things, maybe surrounding weight loss or surrounding that, like, you need to be different? Often that doesn't feel good. And yet, like I don't know that I can say that, or I don't know I can like push back on my doctor. So if a client is like, yeah, it doesn't feel good or it doesn't feel helpful, I actually don't think that is what I was seeking. Then maybe being a little curious of like, well, do we want to do something about it? There are on the Health at Every Size website some like info sheets about common diseases or diagnoses that have been over time associated with fatness that are really useful. They're like weight neutral research into these things. So sometimes I've prompted clients to be like, we could look at it through this perspective. Well, what does this feel like? Or have you heard about this? What would it be like to bring these to your doctor and ask, can we have a weight neutral conversation? I don't want to talk about my weight because my previous attempts at losing weight have been unproductive for me or have been harmful for me. Sometimes, unfortunately, it is like advocacy training for our clients of, unfortunately, right, we're going to encounter providers who, maybe are untrained, uneducated, as I've said, maybe don't know that they're causing kind of this harm. And that doesn't mean that we have to listen to them.
Thank you.
Yeah, is there any things that maybe we need like a refresher on, or maybe I know I was going pretty fast through that training today. Anything people wanted me to expand on at all?
I was kind of curious about how gender plays in to your experience of fat liberation work. Because I was talking to Ben, who is my peer at school, who was in this training earlier, about how for a minute there they were the only male presenting person in the room, and they were a little uncomfortable. They're like feeling like they might be invading the space. And so I just think that's an interesting conversation and like to hear your thoughts.
Yeah. Yeah, I can definitely validate that. A lot of the research, especially in terms of who is most impacted by weight discrimination, unfortunately, is women. And so, whether that be through like history, right, that women were already a marginalized group, and here is some like further marginalization happening, um, or that there is, I think, this general acceptance that fat men are not as, I don't know, like targeted. We have much more allowance for men to be larger than women are allowed to be. Um, you know, Unfortunately, we see this in Hollywood all the time. There are many fat male actors in leading roles or very, acclaimed roles. But casting a fat woman as a main lead is still a rarity, is still like, ooh, they did it. They finally did it. And so I do think that, yeah, women are much more targeted by these things. And I guess I impress upon all people that we're all impacted by this. Um, Even men, even small people, thin people are impacted by weight bias. That's kind of a tenet of health at every size as well, is that we are all living under this form of oppression. So maybe you have not experienced direct discrimination, but you've likely experienced bias. You've likely experienced judgment or shame, even our men. And so I hope that there is space for men in this conversation. I want this to be as inclusive as possible. But yeah, great question. Yeah, Taychell.
Yeah, I was thinking about this because when I've worked in the landscape of diversity, equity, inclusion for a while, and when I think about, I explain white supremacy in the very same way, right? Like you may not think it's affecting you, but it's a part of a system. So this is how I typically describe it, because even when I'm doing DEI work, more of the people who come to the table are white women. So I'm having this conversation, and what I'm saying to them is like, even so, how I usually describe it is like, even if you are the picture of what we say is like the American beautiful woman, right? Which would be like white, blonde, thin, blue eyes, blonde hair, and young, because at some point you won't be that. Even if you stay blonde, you have blue eyes forever, you may not be thin forever, you absolutely won't be young forever. And age is a disability that just happens to people at different ages. We don't have a real schema for when disability is going to come into your life from an age perspective, if you're lucky, right? So when I'm thinking about that, that's how I describe it to lots of people, so that they understand, oh, you're under this bias as well. You're under this culture of supremacy when we're having these conversations. And when I think about it from a weight perspective, as well, people are, we're so the same thing for that comes up a lot for women, is that we're being sold that something about us is not right. So you should buy, eat, or do this certain thing to be whole, right? And it's the constant, and this is the beauty industry, all of it. You have to do it, and you have to keep doing it so that you're beautiful, young, whatever the case may be is. And as you were talking about with like Hollywood, there's like the show King of Queens. There's like a fat man and a thin, that's the ratio. And I think Whoopi Goldberg said it. She said, in Hollywood, an ugly woman the only rule for an ugly woman in Hollywood is being an ugly woman, but an ugly man could be a doctor, a lawyer, or whatever. And just thinking about what that role looks like. So as I'm thinking about this from a perspective of weight, very much the same. One of the other comments I was really thinking about was that I try to infuse into all of the work that I do is really trying to look at this outside of a white supremacist lens and offering that to clients as well, being able to look at engaging in understanding and learning and trainings from indigenous, African, all of these different spiritualities. Because whenever I go to like any modality that I'm working in, I think about how they're incorporating very indigenous Black and brown teachings, but it can still be very white centered. So if we're going outside of that, most of these other cultures have some different, like for me, when I was doing my training in grad school, I thought a lot about um, how some of the protective factors against weight bias for me was culture, right? So in my culture, I wasn't reading magazines and it wasn't coming up as like anorexia, bulimia weren't the same in my culture because it was to be thick, to be bigger was good, right? And that's how so thinking about it that way, I always offer that to clients as well, to look outside of the mainstream and understanding things from indigenous cultures, and that like fat is not bad, the fat liberation, and also the neutrality.
Yeah, great point, right? As much as we can de-center white supremacy, I'm all here for it. And that, yeah, right. So often I think there's this like perpetuation of, well, no, like thinness has always been in, thinness has always been the way. And that's just not true. Even, you know, even white folks used to be much more accepting of body diversity until we saw white supremacy become the major global influence on our world. So yeah, really, really agree with that, Michelle. Yeah, Lily.
I have a question for you. In my experience, I found like the anti-diet, reclaiming body trust, shift that can happen for folks to be really, really like immensely isolating. I find myself wondering if in your experience, I guess just like what you've seen from that. I think once you start opening your eyes to weight bias, you can really see it all day, every day, everywhere. And it almost feels like you're having different conversations than other people in your life are having. And I'm wondering how you help clients as that isolation kind of sets in without feeling like they have to educate people.
Yeah, yeah, truly. Um, yeah, thank you for naming that because as I said throughout today, you know, these are things that we don't talk about, and you can feel almost like really at odds with loved ones, right? When you start doing this type of work for yourself. It is a highly isolating experience. And so something I routinely talk to my clients about is, who do you have in your life that you can talk to this like change in you, this goal in you? And if there is nobody that is easily available in your mind, right? Can we do something about that? Most healing is best done in community, especially when we're dealing with forms of oppression. um, and I think building fat friendly spaces or fat liberation spaces is a goal of mine. I have some ideas of things I might want to do in the future. But yeah, without some camaraderie, without some validation around these things, it's really, really hard. So looking for community if possible. I think, as you said, not feeling like you have to be the one to educate or push back on your loved ones or people in your life. Again, this is maybe some like advocacy training. We're allowed to say, well, I don't really want to talk about that anymore. Or, yeah, I'm not really interested in conversations centered on weight. Which is, you know, even myself, I've interacted with people in the world and like said things like that, and people don't quite know what to do because it's so normalized to be like, oh, I feel so fat today, and then get a response, right? Get something from that. There's a lot of socializing and connection being formed on talking badly about your body or feeling bad about your body. So finding places where we're allowed to say no and find people who are like-minded or share value here really, really is important.
Thank you.
Final minute, any last thoughts for today? Okay. Well, thank you so much for being here today, taking some time. I just can't say what it means to me that so many people want to be here and want to learn and maybe practice some more weight neutral care. So thank you, and thank yourself. You're helping your clients so much by having this information.